person. I've got a couple more questions. The College of Emergency Medicine has called for detailed modelling of the London Ambulance Service to ensure that extra man of the service is factored in. How's that played out in terms of the Hammersmith closure, but also with what you're looking to do with Charing Cross? And why weren't those figures, if you have carried out that detailed analysis as recommended by the College of Emergency Medicine, why weren't those things in your presentation? You've got the new presentation, and I missed them. Please flash them up.
Not read the paper, that's all. Councillor Brandon, could I ask the big question?
You messed it up. If you could answer the question, I can see the Councillor for Town was keen to defend your case, which wouldn't be the first time, but if we could get back to having professionals, medically qualified professionals answer the questions, that'd be great.
So the analysis is in your paper pack. We had discussions with the London Ambulance Service. We've done that work. For the changes overall in the entire programme, they need an extra 8 crew, and we have given them the funding for that. We're working with Health Education England to help them with recruitment, to problem across the London Ambulance Service and recruitment for paramedics and training of that. We're working on that scheme.
The College of Emergency Medicine has questioned the comparative skills of GPs, which Councillor Bowles touched upon when he was talking about paediatric. Have you got a full analysis, a skill set analysis, that demonstrates where you think GPs have the right skill sets and where you think there are learning gaps in order, given that sudden changes are happening? So what I'm looking for is what are the skill sets will be ideal for GPs, or what is your objective assessment of where GPs are currently at? And given the College of Emergency Medicine raised this as an issue with you, then I guess you have a very detailed response.
Yes. That is the answer to the question. Yes, we've done a gap analysis between what we feel the skill set should be for a GP working in an urgent care centre with those shaping out the future criteria. Yes, we've compared that to what the skill sets are for the GP population who are willing to work in the urgent care centre. We've worked with Imperial, with Dr. Ruth Brown, who's been leading the project on Imperial's behalf, who is also a member of the College of Emergency Medicine, to identify what training would be necessary. There's a number of different...
Sure. Can you? Yeah. It would be helpful in the time if you could just list.
Sorry.
If you could list what that gap analysis is, because I couldn't find it in the papers.
I'm not sure I'll cover this in complete detail. I know there's going to be training offered in terms of ECG interpretation, X-ray interpretation, recognition of a very, very ill child. I honestly can't remember what the others are, but we can provide that comprehensive list for you.
Okay. Any explanation why it wasn't in the papers, given that it was such a long set of presentations? And it's so critical to the change you're trying to deliver?
It is in the supplementary agenda in the assurance framework.
I didn't, it's not on the page. I didn't find it.
Should I have a look for you? I'll come back to
okay,
you.
all right. I'll ask someone else a question while you look. Could you? Right. What is the percentage of people admitted to A&E who you think will be treated in the community from the Charing Cross and Hammersmith closures? This is the word in there, closures.
So there will be an increasing number of people treated in the community.
Yep.
Professor Orchard has outlined the ambulatory care models that are developing and the elderly care assessment unit. But that isn't the basis of the modelling for the closing of Hammersmith Hospital A&E. The basis for that is that in order to deliver to the timetable as suggested by the Secretary of State, we have comparable capacity on different sites, and in not the same capacity, slightly more capacity within the acute sector that covers the expected changes in terms of patient flow and patient numbers. So this is not a plan that's predicated on more people being treated in the community.
Sorry, I do appreciate it's getting late, but I will repeat the question again. What is the percentage of people currently admitted to A&E who could be treated in the community once Shaping Healthy Future is played out, and your changes to Charing Cross as you envisage making them, and your cuts to Hammersmith and Charing Cross have played out? What is the exact percentage you're working to?
Someone,
You don't have to answer this yourself, Dr. Spicer. It could be everyone on the panel.
I'm trying to work out what the denominator would be and what the metric would be. I haven't got an easy way of giving you an answer to that.
Does any? Okay, well, that's fair enough. But you have a lot of people here. Does anyone know, Dr. Spencer? Do you have any idea, or Dr. Batten? Who's on top of this brief?
I don't have the number with me. I can certainly provide what was done as part of the DMBC when we were working out the bed capacity that was needed.
Okay, can anyone bail 2 GPs out, I've asked? Dr. Batten, are you aware of this figure? No? Okay, well, I think it's critical. It's the basis of your premise of the presentation.
It's based on the assumption that 20% less hospital admissions and that the length of stay will be reduced by 15%.
It doesn't, yeah, I don't think that doesn't answer the question, but I think you're going to have to write to us. So just as it is all being recorded, so you'll be able to, and you can listen to the recording on the web. But I'd like a specific answer written about that specific question, because we are, as you know, carrying out our own analysis of what we're doing. Can I ask, in terms of your views on the old Open College Park development, I know Mr. Elbleys in the past referred to the census data and the GLA references to census data. What is your estimate for the increases of population over the next 10 to 15 years following that development? I myself have a lot of meetings with the London Mayor's office and with people internal here, so I'm fully aware of the figures, but given these changes and the projections you're working to, what figures and how do you counter that in to the change in population locally? So how many extra households do you think are going to be living in the new developments in the Norfolk Borough, and what figure are you using? How did you come to that figure, and how do you tie that into this analysis?
Again, you don't have those details here because that isn't the discussion tonight, which is around the A&E figures. I think, as you know, we discussed before, we use the GLA predicted growth in population in calculating the demand on those sites.
Yes, but housing policies make differences, populations change depending on what type of tenures of properties are being built, and as I understood it when you were putting together Shaping Healthier Future, which I first started to scrutinise, I think about 2 years ago now, the premise was very much that you had rock solid population figures, but that's a moving feast. I'm sure you won't be surprised to know that. What I'm asking, given that you're about to recommend that you go ahead with this, I'm asking is what reviews have you done, and in terms of the specific developments, some of which are extremely high profile, such as the planned development area in the Norfolk Borough around Old Oak and College Park, that has significant numbers. Are you telling me you have not reviewed the population projections since you carried them out 2 years ago?
Those figures we reviewed for part of an outline business case development, which is a different subject, isn't it? As Dr. Spicer outlined, the changes to the A&E department at Hammersmith and Central Middlesex aren't predicated upon changing hospital mission or changing activity. As you've already heard, the PD service at Hammersmith Hospital is seriously deficient. It's not run by A&E doctors. We're providing a better service in the future by concentrating on fewer sites.
Well, that's certainly a headline point, and I've heard you say it for many years, but clearly it's our job to scrutinise the details behind how you reach your conclusions, and that's what I'm asking you for. So I'm going to take that answer as saying no one knows, or no one has reassessed the population figures since they were first talked about. And if I remember it, it was based on the census figures and with additional data brought in by the GLA 2 years ago. But I'm understanding you to say this is not being reassessed in the 2-year period that you've been working on this. If you want to correct that, then please do write to me with details of what the population reassessments are. I think the committee would like to see that information as well.
Can I just get back to you with the thing I was thinking?
Yeah.
So it's on page 64 of the supplementary agenda. There's a list of what the educational aspects of the work for the recent GPs maybe.
So how objectively was the gap analysis carried out? While you're telling me that, I'll have a look at this on page 64. What methodologies, what human resource and training methodologies did you use to carry that?
Okay, I would have difficulty answering that question because I don't know what methodology was used to carry that, and I don't think there's anybody here who would know that. We had a specific urgent care work stream in the programme, so I will be able to get detailed information of that back to you, but I can't provide it right this minute.
This doesn't look, I mean, I'm very familiar with gap analysis. This doesn't look like one. It looks like a list of areas you want to do some training and development in. In fact, I'm not even sure it's that. I'm struggling to read through this. Is there a gap analysis?
I beg your pardon. Sorry, I thought you were asking me if there was a list of what the training requirements were. There is a gap analysis. The gap analysis was done initially and was revised on the 16th of July. I'm sure we can get that to you.
It strikes me, Calderback was opening up a vein of interesting analysis earlier, in the sense that if it is true that there's no paediatric response in some cases, and that's going to be part of the gap analysis, then it's also true that there could be a variety of other quite sophisticated gaps in the knowledge of GPs. I have personal experience with GP misdiagnosing my father's heart attack, and it wasn't practically called the ambulance. Much later on, when his sciatica turned out not to be sciatica, as the GP had advised, and actually a heart attack, and he was dealt with expediently at a hospital this time. But the initial misdiagnosis happened by a GP, and I see you've got stuff like chest pain and palpitations, but actually it's not very detailed, and most GPs could easily, again, misdiagnose that type of stuff. So what I would like to see is a very detailed gap analysis, as you would get done professionally, with some maybe notes on the methodology used. Otherwise, we could begin to see some of the economies that Councillor McCall had outlined. I think you can understand what we're saying, yeah? So how quickly do you think we can get that to us?
Well, the gap analysis has been done.
Yeah, so we can get it back tomorrow.
I would expect so.
Thank you very
I
much.
suppose one other thing I would say to you is that the difference in the urgent care setting is not only about the skills of the GP, but actually the access the GP has to investigations and the speed with which they can get results back. It's generally speaking, it's not possible in a GP surgery to access an ECG or blood test to look for evidence of, say, for example, heart tissue damage. It will be possible to do that in the urgent care centre. But yes, we'll get that information to you.
Okay, by the end of the week, right?
Yes.
Thank you. So, in terms of, so what I would like to do a touch more, is because I'm aware we are running out of time, and I'm aware that the chair of the committee would like to ask you some questions. But can I just come back to the point that caused me some concern, which is Dr. Spencer's comments about going to an accident emergency department. You're a professional doctor. Does it not cause you any concern when you hear the communications expert you're working with that people don't understand the difference between an A&E and an urgent care clinic, and given the government's reclassification of A&Es as classified class 1, class 2 and class 3, class 3 being pretty much an urgent care clinic, which is hence the discrepancies on the NHS England's website, do you have any nervousness as a professional doctor that people will be going to the wrong service given that they do not fully understand the difference between the A&E and which well they will get expert care suited to their needs and an urgent care clinic or even a class